Yeah, I'll just very fast go through what I tell collateral damage repair. So this is what I was speaking about secondary surgery. So what we have to do, we have to assess the eye once it cools off, and generally it is taken, after which it is taken up for second surgery, and we should aim for maximum anatomical restoration. So, and think twice before branding anything as unsalvageable, because even ambulatory vision may help the child in later life. So this video, it was a child with a zonular dialysis and cataract and iridodialysis as well. So what we have to do, we have to be very meticulous when planning the surgery. Once we have planned the steps well, I think we can achieve the rest quite easily. So in this first capsular access was performed. And after capsular access, I decided to first stabilize the bag with a CTR implantation. Then the cortical aspiration. Because once the bag is stable, then we are in a position to repair the iris. If the bag is unstable, and that is why I went ahead with cortical aspiration and IOL implantation. And still you can see a thick fibrous PC. So I decided to wait for it as the last step, because after that some manipulation in the anterior chamber may make the IOL unstable. So after IOL implantation, first the iris repair was done, and using the railroad technique, a 26 gauge needle was taken, and through the main port the 10-0 vicryl was pulled out, and it is a double ended 10-0 vicryl. So the second bite was taken, and the other needle was taken out through the 26 gauge needle, and finally sutured in the scleral pocket. So we have a nicely formed repaired iridodialysis here. And once this was done, we went ahead with the posterior capsular access and using a vitrector, because it was and even for normal consistency capsule, I have been using more of vitrector nowadays rather than a manual capsular access, and get a good opening in the visual axis. And this is how it looked at the end of the surgery. This is the pre-op and post-op picture of the same patient. Next, I would show a video. This was a child with a slightly malformed anterior segment. I had done a cataract surgery in this child, and then it developed some minor trauma and ended up having hyphema and obliteration of the pupil. So with a cutter and with visco tamponade, we got a cleavage plane and made a pupillary opening with the vitrector only, and a smaller cut rate. Always during pupilloplasty, to keep it under control, keep the cut rate small, and whatever bleeding is there, you can always visco tamponade, and at the end of the surgery, generally sphincter bleeds, they get controlled quite well. And now we can see the lens behind glistening here. And as I said, this child had some anterior segment malformation which I could never make out, because even in the post-op period you can see the capsular bag has contracted a lot and caused capsular phimosis. So I had to cut the anterior capsule as well in this case to make some respectable size opening. A spatula was just swept below the capsular access to free it from the adhesions in the IOL, and with a cutter opening is made. So this is how it looked at the end of the procedure, and over a period of 2 years now it is maintaining quite good clear visual access, and this was the pre and post op picture of the same. I think I'll stop at this, and thank you all very much for attending this instruction course. We have completely run out of time, so we can continue with our discussions outside if you want. Thank you so much.